And I would like to introduce our speaker for today. So we have an honor for the presence of Professor Annalisa Berzigotti. So Professor Berzigotti is going to give her lectures on the compensated advanced chronic liver disease, Baveno VII, consensus, and beyond. So currently, Professor Berzigotti is the head of the Hepatology and Clinic Director of the University Clinic for Visceral Study and Visceral Surgery and Medicines of the Inselspital University Hospital of Bern in Switzerland. She's also holding a position as the full professor of hepatology, also in the University of Bern, and then research group leader of the DBMR. Let me introduce a little bit based on her CV, if you don't mind, Professor Berzigotti. So Professor Berzigotti, she obtained her medical doctor degree with summa cum laude at the University of Bologna. And after she pursued her internal medicine specialist degree, again with summa cum laude from University of Bologna, and after a PhD in ultrasound in medicine from University of Bologna. And after that, she received many major trainings from Spain and from Switzerland. Until now, she's a full professor of the clinical hepatology at the Faculty of Medicine of the University of Bern. If I read her CV, it's amazing, very impressive. Now, Professor Berzigotti is a member of the several educational scientific boards. Now she's a reviewer for several important medical journals such as New England Journal of Medicine, Lancet Gastroenterology and Hepatology, Gastroenterology, Hepatology, Journal Hepatology. She was also expert reviewer for Horizon 2020 projects of the EU, of the European Commission of EU, member of scientific committee of the European Association for the Study of Liver, or EASL, associate editor, Journal Hepatology, the chair of the EASL Clinical Practice Guideline Panels, the representative council of the United European Gastroenterology, and she received also several major awards and prizes, including the first woman being awarded the prize of Lucy Bolte Prize in 2022. For her scientific productions, until now, she already published more than 250, even maybe around 300 of the peer-reviewed publications with the impact factor of 76 based on Google Scholar. I checked just now. So I would like to invite Professor Berzigotti to give her lectures, her presentations, and then we have 1 hour of the yellow winner slot. So please free to use the slot as much as you can. Thank you very much. So I give the floor for your presentations. Thank you very much.
Thank you very, very much, Professor Sukovati, for this very, very nice introduction. You said even too much about me. So for today, I'm just Annalisa, so feel free to stop me anytime and just ask questions. I will try to go through a topic that is one of the ones that I prefer. So I hope I will be sufficiently clear, but if not, please feel free to stop. And I apologize for my voice because I am a bit in a situation of a cold, and so in case you don't hear, just tell me, please. So the topic that has been assigned to me today is compensated advanced chronic liver disease. And I will try to go through this relatively new concept and propose to you what has been discussed in the last Baveno consensus workshop. And for those of you who are not familiar with portal hypertension, the Baveno consensus is the equivalent of the largest guidelines, I would say, for portal hypertension. It exists since over 25 years, and it gets together once every 5 years to try to provide the best evidence on this important topic. This is my agenda for today. I don't have any relevant conflict of interest regarding this topic, and that's why I didn't list potential conflict of interest. So let's go for the first of these topics, which is the natural history of chronic liver disease, and we will see how the paradigm is slightly changing in the last years. And I'm sure you are all very much aware of the fact that in any etiology of chronic liver disease, if we look at the stage of liver fibrosis, mortality is concentrated in those stages that are advanced, so advanced stage of fibrosis, and in particular in cirrhosis. And once cirrhosis has developed, the stage of decompensated disease, meaning once a first decompensating event has presented, marks completely a difference in mortality risk. And you can see that 10 years after diagnosis of cirrhosis, those patients who were compensated and remain compensated have 80% survival, while for decompensated patients, survival is below 10% at 10 years. And from compensated to decompensated stage, we have a transition of about 8 to 10% per year, which means we should pay attention to the compensated stage. But you know that cirrhosis in compensated chronic liver disease is indeed an histological diagnosis, and the disease is characterized histologically by fibrosis septa, regenerative nodules, hepatocyte loss, and angiogenesis within the septa. However, you are also very much aware that liver biopsy is a totally not perfect standard or reference standard, since liver fibrosis is a continuum, and the differences between an advanced stage of fibrosis and a cirrhosis in compensated patients is often impossible to differentiate even to the best pathology. Plus, we know now that if we can correct the main etiology of liver disease plus cofactors, we can have a regression of fibrosis and not only a progression, which brings us to a concept that is now named compensated advanced chronic liver disease, which is better suited to describe this population ranging F3 and F4, in which the risk of presenting liver-related events is high. So it's certainly not feasible to biopsy everybody, and so we would need some markers that help us identifying this stage of the disease. And this is just a couple of examples of real patients. Here you see that is still considered NASH. Nowadays we would say MESH. This was a compensated patient undergoing biopsy. We wanted this patient to enter in a trial. Our local pathologist said F3. We sent it to the central pathologist in the trial and he said F4. This is another case. Again, same story, but the opposite. Our pathology said F4, so cirrhosis. The central pathology said F3. So again, I think that nowadays we should stay in the concept of compensated advanced chronic liver disease and apply to this larger stage at risk, further risk stratification. So again, since we cannot or we should not likely use biopsy, what can we do to identify this category of patients that are at risk of progressing to complications? And here, the non-invasive tests come into their role. And you know that the ideal test for assessing any chronic liver disease should be non-invasive, reproducible, repeatable, accurate, and therefore objective. Evaluate the whole liver and ideally cheap. Unfortunately, this type of perfect picture of the liver does not exist, but I hope you will be convinced in the next 45 to 50 minutes that we improved very much in the last 10 years in getting closer and closer to this picture. And why? Since we have nowadays really a lot of different non-invasive tests that we can apply to our patient with compensated liver disease to try to get closer to what histology would tell us, and even beyond that. So we can use blood-based tests. Some of them are very unspecific and include the simple liver function tests or transaminases or a combination of simple tests and clinical variables. Some others are a bit more complicated and patented and therefore cost some money, like FibroTest, ELF, or Fibrometer. And these are the blood-based tests, but we can have a physical approach and imaging approach to our liver disease. And as for physical approach, there have been many advances in what we call elastography, and we will get more in detail in a moment on it. Of course, imaging maintains an importance because it shows the anatomical characteristic of the liver tissue, plus with magnetic resonance imaging, we have access to several other characteristics closer to the biochemical properties of the tissue itself and its function. Very quickly, as for the indirect markers of fibrosis, again, some of them are very simple tests such as AST, ALT, bilirubin. All of these have somehow a correlation with the advanced stage of fibrosis, but none of them, not even in combination, go beyond a prediction of about 80%. So in our area under the ROC curve, maximum of 0.80 to identify an advanced stage of fibrosis or cirrhosis. There are more sophisticated tests, and some of them are summarized in panels or used in combination in panels, such as the European Liver Fibrosis ELF test that use hyaluronic acid, procollagen type 3 and TIMP1 associated with age in a formula, and this provides a quite close picture of the degree of fibrosis. However, we should also remember that we are looking at a dynamic situation that can change, and age, of course, does not change in both directions. It only goes in one direction, and therefore, when we look to regression of liver fibrosis, none of these panels at the moment proved really a perfect ability. Elastography is a totally different type of test, and therefore, in some instances, the combination with blood test is improving the capacity of identifying fibrosis. Elastography is based on the concept that an impulse, either a mechanical impulse or an ultrasound pulse, sent to the liver will generate micro displacements in the liver that we can measure if we have a device, and in this case it will be an ultrasound device, able to look at the velocity of the waves that are generating into the liver, which are the so-called shear waves if we use the most standard ultrasound elastographies. The most common device used is the vibration-controlled transient elastography, or FibroScan, that allows to measure the stiffness of the liver through a vibration sent to the liver and through assessment of the velocity of the shear wave through a small ultrasound probe positioned on the tip of the probe of the device. And as for cirrhosis, since we are looking at all studies where still this term was very much used, this is indeed the guy to beat, because as you can see, in this paper and many others that have been published since then, the capacity of discriminating cirrhosis versus previous stages is very, very high using liver stiffness. And if we are strict in looking at those patients in whom we obtain not very variable measurements, meaning an interquartile range over the median value very low, so below 10% ideally, and at least below 30%, we are relatively sure to be looking at this stage if values are above 12.5 kilopascal. There are, of course, some issues with the applicability of the tests. Some of them are obvious, like the operator experience. Others were related to obesity, which has been overcome by, in part at least, by a new type of probe, which is the XL probe, which is particularly designed for obesity. We have also to know that as any quantitative test, the higher liver stiffener, the higher the risk of the condition that we are looking at, in this case, liver cirrhosis or advanced stages of fibrosis. And this test is excellent in ruling out this situation. If values are low and below 10 kilopascal, we are outside this risk in most of the situations. And it is not perfect in discriminating between adjacent stages of fibrosis, but again, it's a matter of risk. And the higher we go, the higher the risk of cirrhosis. Of course, will depend on the specificity we ask from our cutoff, what we are going to look and to diagnose. We have to be aware that stiffness of the tissue is not just fibrosis, and despite this is the major component of liver stiffness, there are other characteristics of the liver tissue that contribute to stiffness. For instance, congestion in case we have an increased venous pressure, mechanical cholestasis, food ingestion, infiltrative diseases such as, for instance, inflammation per se, or amyloidosis, or lymphomas, or solid tumors. In part, probably fat, if it is very highly present, and hepatocytes edema, for instance, in case of acute hepatitis. So if we have some of these confounders, we have to know, and this is why this test should be done by physicians aware of the clinical situation of the patient, because we are now confounding the relationship between fibrosis and stiffness. So stiffness is high, but is not due to liver fibrosis. So we have to be aware of this. Anyhow, we can also use other type of more modern elastographies that are embedded into ultrasound devices. The concept is, however, always the same. Despite the tissue is stimulated not by a vibration, but a direct impulse of an ultrasound, still we are measuring the shear wave velocity, which is proportional to the stiffness of tissue, which is, in the absence of confounders, proportional and very proportional to the amount of liver fibrosis. And it does not matter too much which type of device we use, because if we know the algorithm and the cutoffs proper of the device, we will get always the same information, and this is an accurate information. Some of the devices have even similar thresholds, but not all of them. So we have to be aware of which device we are using and which are the cutoffs suggested by the manufacturer. Having said that, the very, very large majority of evidence in any of the settings that I will show you today have been obtained by the use of transient elastography, so FibroScan. And so in the next slides, I will almost always refer to this technique. So having said that there is such a good correlation between liver stiffness and fibrosis, and that there is some problem in identifying adjacent stages of fibrosis, however, remind that we would like to identify a new category of patients, that is the so-called advanced compensated liver disease, which joins F3, F4, because we assume that even with biopsy, we are not perfect in saying who is who, and therefore we want to focus on risk. So we go away from the pure histology, we want to go to risk of developing event. And for this, transient elastography, we will see, is an excellent tool. And in this group of patients, we should further refine our prognosis, knowing who has or who will have clinically significant portal hypertension. We will go more in detail into this in a few moments. Why is it a good tool? You can see here some very large data on systematic review and meta-analysis of the published data. If you look at very large numbers, so thousands of patients with chronic liver disease followed up, you can see that there is really a proportional increase of risk of developing liver-related events in general, so including HCC and death, and first clinical decompensation, the higher the value of liver stiffness you are looking at. And if you look well, if you go below 10 kilopascal, the number of patients developing events is really very, very minor, while if you go beyond 25 kilopascal, the risk is maintained more or less stable, so you are achieving a sort of threshold of risk. And this is the information that the Baveno VII consensus conference used to state that the higher liver stiffness, the higher the risk of liver-related events, and that we can define who is this patients with compensated advanced chronic liver disease, namely patients with a liver stiffness measurement above 10 kilopascal. And this is another analysis on another population stating exactly the same. You can see that below 10 kilopascal, the risk of developing events is really practically negligible. And this is the so-called rule of 5 that is now become very much used in clinical practice since its publication first in 2021 by Pons and other colleagues from Spain, and has been refined in the Baveno VII consensus in 2021. And you can see that you can exclude then compensated advanced chronic liver disease when you are below 10 kilopascal, remembering that liver stiffness is better at ruling out than at ruling in. You have a sort of intermediate area of uncertainty between 10 and 15, where, however, you can say that there is certainly already a relevant fibrosis going, and above 15 kilopascal, you can assume certainly that the patient is in this situation of advanced chronic liver disease at risk of developing further events in the future. And this is what the recommendation said. So we said that is a pragmatic definition, this compensated advanced chronic liver disease, but it can be used because it allows a point of care close to bedside assessment of risk in your patients that can allow you to go faster in determining what other tests are needed or what rule for treatment can be done. Of course, if you have histology, you can rely also on histology, but I can tell you from on clinical grounds that sometimes liver stiffness and histology are somehow not identical, and risk is better reflected by this numerical value. So again, 15 kilopascal is the threshold that highly suggests compensated advanced chronic liver disease, but even values above 10 are already suggested. If you want to be even surer of whether you are in this situation of risk, you can add other tests. For instance, a simple imaging, ultrasound imaging, using a high-frequency probe on the left liver lobe can tell you whether there are nodularities, and nodularities are very specific of advanced chronic liver disease already in a histological cirrhosis stage. And this can be done with ultrasound or can be done with a CT scan that can automatically quantify the nodularity, and this correlates well with prognosis. And combined to the other tests that we have seen, you reduce very much your uncertainty on determining whether your patient is really in a situation of risk or not. There is much more that you can use. I will not get into the details of multiparametric ultrasound methods, but if you are interested on the different ultrasound societies, you can have many more data on what else is being used to diagnose this advanced stage of fibrosis. So now we know that our patient is in the situation of risk. What should we do? We should remind the clinical stages of advanced liver disease. And advanced liver disease, again, is in a compensated phase where the driver of prognosis is portal hypertension. And when portal hypertension appears, the patient becomes to be at risk of developing decompensation. And again, it's a totally different disease when patients develop decompensation, since death becomes a much more frequent event, and we should then therefore try to prevent the onset of decompensation. And this is why it's so important to identify this threshold of portal pressure, which is 10 millimeters of mercury measured by the gold standard method, which we name clinically significant portal hypertension, because above this threshold, all events that are clinically relevant for patients can appear. And this threshold of pressure is an independent risk factor in all major liver diseases for developing decompensation together with albumin, so liver function, and other clinical aspects such as obesity. And despite the ongoing controversy now, we have a lot of data showing that also in MASLD, or as so-called in the past NASH, it's also the same. So it's not true that patients with with low pressure can decompensate. Only few of them, and only in very, very rare situation. The majority of those who will develop decompensation have an HVPG, so a portal pressure above 10 millimeters of mercury, and this has been validated in a large population international study just published in the Journal of Hepatology, validating the concept that if you are below 10 millimeters of mercury, your risk of developing decompensation is very, very close to zero in the following 5 years. And therefore, this is what we should be able to identify non-invasively, because if else we should measure HVPG in all, and we know that this is not possible. Why we should be able to diagnose it in non-invasively is because we could treat it, because if we can go below this threshold of risk through pharmacological therapies, we will prevent the onset of complications, somehow reverting the natural history. And there is a very important study, which is a randomized control study versus placebo, published in Lancet a couple of years ago, from the multicentric group in Spain, showing that in those patients who have a clinically significant hypertension and not yet the classical criteria for being treated with beta blockers that in the past were large varices, so these patients do not have large varices per definition, but they do have clinically significant portal hypertension. If we start treatment with non-selective beta blockers, we can prevent the onset of any type of decompensation with a reduction in risk close to 60%. So it's really a large advantage of our patient. And therefore, this concept that has been validated externally already in several different meta-analyses and in epidemiological studies in the US is something new that changed the paradigm. So now non-selective beta blocker should be started early as portal hypertension is diagnosed. And therefore, I can guess you can understand how important it would be to be able to identify this threshold of risk to trigger start of treatment by using non-invasive tests. Let's see if we can. So again, we can use the same test that we saw before. Now we are in the setting of identifying portal hypertension. Therefore, we should be very specific and not too vague, because else we would start treatment in too many people who do not need it. Of course, the standard laboratory tests are not enough. The best is platelet count, but it is very, very not sensitive and not specific. Even if platelet count is low, it can be due to other causes. We have imaging techniques and transit elastography, and we will see how we can use it in a combination. Of course, ultrasound is what we have in our hands as physicians. We can use it because in case we see portosystemic collaterals, the diagnosis of portal hypertension is certain. It's, however, unfortunately the case in a very small minority of patients, and their absence does not rule out portal hypertension. If we see them, however, we are sure to be in this high-risk situation, and we know from other publications and large studies looking at CT scan and MR that the presence of portosystemic collaterals is not only a sign of portal hypertension, but is also an independent predictor of clinical events. And therefore, this would be sufficient to state, okay, patient has a clinically significant portal hypertension, we have to start treatment to prevent events. But what we have today is something that allows us to be much more sensitive. So we said that these data on imaging are specific but not sensitive. We need to be sensitive, and this is elastography. And we will focus now on liver elastography, and liver elastography can help predicting portal hypertension, since the major factor leading to the increase in portal pressure in the early phases of advanced liver disease is fibrosis, which increases resistance to flow. And increasing resistance is the major driver of increasing pressure. Later on, there is also an increase in portocollateral blood flow, which is a compensatory response. However, this part is not properly reflected by liver stiffness. And if we look at the meta-analysis looking at if liver stiffness is able to predict somehow the presence of clinically significant portal hypertension, we see that there is an excellent discriminative capacity with an area under the ROC curve of above 0.90, and I tell you that is almost one of the best that we have for any test in medicine. And if we look at that, an ideal cutoff, we always get into cutoffs between 20, 25, or 25 kilopascal. And this has been confirmed recently by a meta-analysis in 26 studies and over 4,300 cases having the gold standard method, so the HVPG measurement available. We can do even better if we combine non-associated or non-related tests, for instance, spleen diameter and platelet count added to liver stiffness. But the major role is indeed due to liver stiffness. Without that, we would be unable to predict the presence of portal hypertension and varices. And importantly, liver stiffness does not only mirror this threshold of pressure, but it mirrors the risk associated to the pressure gradient. And you can see that in different studies published, comparing to the HVPG, liver stiffness above 20-25 kilopascal was as good as the HVPG in predicting survival. And the higher the risk of decompensation and death. Of course, the same concept applies also to other techniques more sophisticated that are mostly used in the United States, such as magnetic resonance elastography. Again, the concept is similar. There is a vibrating element that allows to create the movement, the wave into the tissue, but then instead of using ultrasound to measure the velocity of the waves, magnetic resonance is used. The advantage is that you see a full liver, of course. However, it's anyhow only possible in slices and not at the moment three-dimensionally. There is some development on that, but not yet in clinical practice. However, this is very expensive. It takes a very long time to do the examination, and I think it will never enter clinical practice as a routine due to this, at least in Europe. So if we look at what we said into a more pragmatic way, we can state that above 25 kilopascal transient elastography, liver stiffness, we are in over 90% of cases in a situation of clinically significant portal hypertension. This is true except in one condition we will see in a moment. We can exclude portal hypertension if we have values below 15 kilopascal with normal platelet counts, and we have an intermediate gray zone between 15 and 25 kilopascal, where the probability of having portal hypertension is somehow intermediate. And we will see in a moment what we can do with that. The special situation where we cannot assume that above 25 kilopascal we have portal hypertension is muscle D with obesity, because liver stiffness in this situation can overestimate fibrosis and therefore portal hypertension. And we can, however, use other variables to refine this test, and this is body mass index and platelet counts in the so-called anticipate NAFLD model. And you can see it here. Using these additional parameters, we can end with a rule, a simple rule, a model that can allow us to be much more sure of whether the patient is in a situation of portal hypertension or not. And this model has been validated already in two external cohorts, one published in 2023 and one this year. We can also take advantage of other tests, simple, such as those we described at the beginning. For instance, the FIB4 is just a very simple equation using age, AST, ALT, and platelet count, which is used in the screening of fibrosis in muscle D. But if we use the cutoff that is suggested for cirrhosis with FIB4, we can somehow understand whether what we are measuring with stiffness is a false positive result, and then clarify much better what the category of risk of our patient is. So we can do several tricks and combinations with our non-invasive test to get closer and closer to the real picture. If we have ELF available, this is at the moment the best non-invasive serum marker or combination of serum marker that we have available. It is, however, patented, and the FDA has just approved it as the first blood-based biomarker in muscle D. So in the United States, it will likely be used to guide the access to therapy of muscle D with the new medication. As we said before, there is a problem with this very simple rule of 5 that we already use, which is this gray zone. So we want to stratify the risk of our patient, and many of our patients, like 60% of them, will fall into this category between 15 and 25 kilopascal. And therefore, in this patient, what should we do? First of all, we should already remind that their risk is consistent to an intermediate risk, so it's not zero. Zero risk is in the group in which we can exclude non-invasively portal hypertension, and this has been validated by 2 independent studies. This is a very large one performed in Asia, and you can see in yellow those patients who had a stiffness above 25 kilopascal, and that's really a very high risk. Those in red who have a liver stiffness below 15 with normal platelet count, so no risk, and indeed no risk of events, and in the middle, the intermediate risk of the gray zone. So the concept of gray zone is confirmed, and the same in this other publication, which is very recent. So we should try to be much surer of what is the category of risk of these patients. What we can do is either do the standard, which is go to endoscopy. You remember the Baveno VI rules, which were allowing us to rule out varices at risk. And this is just liver stiffness below 20 kilopascal with normal platelet counts. And this is really very, very well validated. In this patient, we can skip endoscopy. In the others, we do endoscopy. If there are varices, of course, we are in a situation of risk. But much better is to go to novel methods, and we will get to that in a moment. Looking at this category of patients, I think it's very important to look, however, at what are the cofactors that play a prognostic role, because we should pay attention to sort of manage them and not just take the risk as it is without trying to modify it. And one of the important cofactors we should pay attention to is the nutritional status. We usually talk about malnutrition when we see an undernourished patient, but we should be aware that overnutrition is another type of malnutrition, and obesity is a very, very major modifier of risk in our compensated patients, whatever the etiology of liver disease underlying. And you can see in this study performed some years ago in a very nice population, because it was a population of a randomized control study, and therefore prospective and very study much in detail, we could prove that obese patients had a much higher risk of developing adverse decompensation, and that BMI was an independent risk factor for clinical decompensation. And based on that, we assumed that if we could make our patient lose weight, we could have a benefit in terms of improvement of portal hypertension, which we could prove with this intervention study, 16 weeks of exercise and diet in obese patients with compensated cirrhosis undergoing HVPG. And you can see that after these 16 weeks, 42% of these patients had a decrease in portal pressure that was proportional to the decrease in body weight, and was much more often observed in those patients who had lost at least 10% body weight. And this proves that there is a component of portal pressure which is dynamically mediated. Of course, we cannot achieve a decrease in fibrosis in such a short time, but as for the vasoconstrictors that are probably mediated by insulin resistance into the sinusoid of the liver, if we can reduce insulin resistance by losing weight, we can improve portal pressure. And other body composition markers influence the course of liver disease. For instance, subcutaneous fat with high density is a marker of dysfunctional adipose tissue and is associated with higher cardiovascular risk in the general population. And in a study performed in the United States, it was associated with a higher risk of clinical decompensation. We can also state that sarcopenia, and you know that there are lots of obese patients that have sarcopenia despite being obese, is an independent factor of prognosis and of decompensation in this category of compensated advanced chronic liver disease, meaning that we should make our best to reverse these malnutrition states to try to improve prognosis in our patient. And importantly, this is independent of portal pressure. Despite there is an interaction between nutritional status and portal pressure, both are important and are not exactly the same. And we can do a lot. I will not, of course, enter into details, but we can really do a lot using nutritional supplementation to improve muscle mass, whatever the BMI of our patient is. And for instance, what we can use is a supplementation in branched-chain amino acid, which really improves the skeletal muscle mass of patients. There is another special situation that we should pay attention to, which is patients who had a cure of their hepatitis C, so their etiological factor has been removed and have achieved a sustained virological response. And in this population, sometimes we guess whether the disease has regressed and portal hypertension disappeared, or whether we are still in a situation of risk. And importantly, since the last Baveno consensus, we know that we can use non-invasive tests also in this special situation. We know then that the regression of portal pressure is a slow process, but it is ongoing. So after 2 years, after 6 months, sorry, from the sustained virological response, there is already a decrease in portal pressure, which goes beyond that over the next following years. And there is a large proportion of patients with improved, but a non-negligible proportion, about 30 to 40%, remains at risk of developing events. We know now that if we use FibroScan or liver stiffness and platelet count, we can know which patients are no longer in a situation of risk, meaning liver stiffness below 12 with normal platelet counts can now exclude portal hypertension, and this has been proved comparing with the gold standard HVPG measurement, while again the famous number 25 kilopascal keeps predicting the presence of portal hypertension. And we can use these simple rules to state how we will follow up our patients for portal hypertension, but please remind that the risk of cancer, so of hepatocellular carcinoma, remains, and HCC screening must be continued independent of any of these thresholds of risk for portal hypertension. What we can do better is to use not only the initial picture that we were mentioning at the beginning, so a first assessment of stiffness and non-invasive test, but use them in a dynamic way. So let's see what happens to the patient over the follow-up. And there is good data suggesting that an increase in stiffness of at least 20% is associated with a worsening of prognosis with higher risk of decompensation and liver-related death, while on the opposite, if we observe a decrease of stiffness below 10 kilopascal or at least below 20, we are observing a patient whose risk has decreased at least by 50%. And this has been stated by this large study performed in the University of Vienna, confirming in different etiologies this, and has been further let's say, refined by this other study just published in Hepatology, which, however, makes the point that the value, not much the delta of values, but the final value that you are looking at the moment when you are re-evaluating the patient over the follow-up states or predicts is correct risk. However, I think both concepts are important, and they mean that one picture is not enough, and we should use our non-invasive tests over the follow-up in an intelligent way to really understand what is the current situation of our patient. We need to become even better. We saw that liver stiffness is good, but it's not perfect. What we can do nowadays for better stratification is to use the spleen stiffness. Spleen is an organ that is very much influenced by the presence of portal hypertension because it becomes congestive and increases in size, and congestion is reflected by stiffness of the organ. So if we can measure its stiffness, this will reflect much portal pressure, likely even better than liver stiffness, because here we are getting rid of the problems of confounders. And indeed, there is data suggesting that the correlation between HVPG, so the gold standard, and spleen stiffness is better than the correlation between the HVPG and liver stiffness. And now we have a specific probe, or let's say not really a probe, a specific software module using the probe we also use for liver stiffness, but a different hertz amplitude, which is 100 hertz instead of 50 hertz, which is specific for the spleen. And using this novel tool, we have a technical success in the vast majority of patients, 92% versus 70% when you are using the off-label 50 hertz for the liver, let's say. And the inter-observer and intra-observer agreement using this novel tool is fantastic. And I think those of us who are lucky to have this module in their devices can really confirm that this is a simple tool to use. And why it is interesting? Because if we can add the measurement of stiffness of the spleen, we are able to sort of disimpact when we are in the gray zone. So if we see a spleen stiffness above 30 kilopascal, we can really state that this patient has a situation of hypertension, so decreasing the gray zone where only using liver stiffness and platelets, we were unable to state whether the risk was high or low. And this has been confirmed by a very large individual patient meta-analysis published last year, which confirms this concept. So using spleen stiffness in addition to liver stiffness and platelet count, we can get much closer to the reality, reducing this uncertainty to a maximum of 20% of patients, and this has been now endorsed. So this rule, this potential of using this tool, it has been endorsed by the last World Federation of Ultrasound in Medicine and Biology guidelines. We can also use other type of tests. This is something not routinely done, but could enter into routine because it's relatively simple, which is measuring the von Willebrand factor antigen additionally to platelet count. The von Willebrand factor antigen is a marker of endothelial dysfunction, and it correlates with the presence of portal hypertension. And if we can measure this ratio between von Willebrand factor and platelet ratio, we obtain the vitro score, and the vitro score, in addition to the Baveno criteria, so this liver stiffness and platelet count, is able to understand much better the category of risk of our patient in those who were else not in a clear situation. There are lots of developments that I will not enter into detail, but just to let you know, multiparametric magnetic resonance is getting closer to a better understanding of liver tissue, and I am convinced that in the next few years we will have sophisticated tools to probably measure pressure, or at least know which patients are in a situation of portal hypertension. And we have a novel contrast-enhanced ultrasound tool using a specific algorithm and a specific contrast, which is called Sonazoid, that is used mostly in Japan, but can be used also in other countries off-label at the moment, that allows us to estimate pressure based on the amplitude of ultrasound measured on administration of contrast. Why? Because the microbubbles, which are extremely interesting tools, while they are in a liquid, have the characteristic that a subharmonic amplitude, which we can measure, have a decrease that is linear with increases in the fluid pressure. So if we can measure the subharmonic amplitude in both the portal vein and in the hepatic vein through a correct equation, we can estimate fluid pressure, which is total pressure and systemic pressure, and then measure a gradient. And in the first studies, this method was very well correlated with the HVPG, and we are part of a large international consortium trying to validate the method also externally. I would like to say only a couple of words on the future perspective, since I think the dream of anybody of us working in the field of hepatology is someday to be able to revert cirrhosis, meaning going from a totally decompensated situation to a recompensated disease where we can decrease portal pressure and restore normality of the liver tissue. Of course, we are very far away from this, but we know already that removal of etiologic agent, cofactor treatment, nutrition, statins, and exercise play a role in getting closer and closer to this. Of course, not in everybody, but in a proportion of them. And we know it from studies looking, for instance, at hepatitis B after sustained suppression of the virus. And you can see that really a large proportion of patients with cirrhosis undergoing treatment with entecavir were cured from their cirrhosis 5 years later. Only 1/3 of them remained in a situation of cirrhosis, and interestingly, these patients were those who had obesity and therefore had a cofactor which was not solved. The same is observed when you look at regression of NASH. You can still see that a large proportion of patients can have a regression of cirrhosis, for instance, when you undergo bariatric surgery. What we do not know is, however, what is the point of no return, what are the, let's say, mechanisms driving the lack of cirrhosis regression, and we should then study much more in detail this. Here I just listed some of the cofactors that are known to impair the regression of liver cirrhosis, which are diabetes, obesity, alcohol, ongoing consumptions. There are likely some genetic factors prompting progression, and some of them protective against progression, but indeed there is a lot that we do not know yet. And this is something we got interested in at our lab in Bern, and our hypothesis is that per se, a stiff extracellular matrix, meaning the stiffness of the organ, could per se be a driver of fibrosis progression or lack of regression. And this is because we know in other organs that cells interact with the surrounding extracellular matrix and sense the stiffness of the environment, and they adapt constantly the phenotype according to the environment, and several types of mechanical forces could then impact on these cells in liver fibrosis, such as strain, shear stress, and even portal pressure by hydrostatic pressure. And so we started to study this some years ago, and we then advanced in our knowledge, looking at the different type of liver cells. What we could prove is that indeed cells from healthy animals cultivated in stiff environments, so in matrix gels of different stiffness, increasing stiffness, develop a phenotype which is close to a phenotype of cirrhotic animals. And on the other hand, primary cells extracted by animals with cirrhosis and cultivated in low stiffness matrix gel had over time a normalization of their phenotype and behaved later on exactly like healthy cells, proving that indeed this is a factor that impacts the cell biology. And we think, and we could prove that this is due to the fact that extracellular mechanical forces through specific proteins lead to intracellular tension and to the deformation and stretching of the nuclei. And you can see the difference in size of the nuclei in cells cultivated from healthy animals into high matrix stiffness and the opposite. So there is definitely much more to understand. And if you are interested in this topic, please take a look to this review which we wrote last year for Journal of Hepatology reports looking more in detail in what is known and not known on mechanosignaling, mechanotransduction, and mechanobiology of the liver. And we can modulate the biology of liver cells in compensated advanced chronic liver disease already nowadays by doing something simple such as giving statins. Statins normalize or improve very much the phenotype of endothelial cells in the liver and improve prognosis in our patients with compensated advanced chronic liver disease by reverting the dysfunction of the endothelial cells. So this is my conclusion and my personal view, which is not yet supported by strong data, but in the Baveno cooperation, we are working to produce the data and to prove that we can get closer to a Framingham score for risk stratification in patients with compensated advanced chronic liver disease. I hope I could give you an idea of the complexity of the field. There is much more we do not know yet. And I think that stiffness impact on biology of the cells will bring novel therapeutic strategies and targets in the next few years. But in the meanwhile, we can pay attention to the several cofactors. We can use our non-invasive tests as a marker of what is being experienced by the patient in the different moments of his natural history. And we can use non-selective beta blockers already early in the natural history of the disease as soon as we can diagnose portal hypertension by using non-invasive tests. I think this is already a lot more than what we could do just only 10 years ago. And I am really looking forward to the next steps. This is what I think the next steps can see in the next few years. By now, we are already able to start beta blockers only in a proportion of patients. We will start beta blockers in a much more personalized way in the near future. And hopefully, we will also be able to state which patients have regressed, and we can really stop medication that is no longer needed, getting closer and closer to a personalized use of medical resources that are being so limited nowadays in our population of patients with cirrhosis. So these are my very few take-home messages, which I already summarized, so we will not get into the details. Remind the rule of 5, I think is simple to use. Remind that I think in patients with compensated advanced chronic liver disease, which should guide our therapeutic efforts by knowing the physiopathology of the disease and trying to treat the different components of resistance and flow. And I hope I could bring you a bit into a glimpse in a fascinating and dynamic field of research. And I thank you very, very much for your kind attention.
Thank you very much, Professor Berzigotti, for a very impressive and comprehensive lecture.